AI Grand Rounds. As we were putting together the calendar of Grand Rounds for this year, Dr. Scannell and I decided we wanted to try and make sure we incorporated some educational information and content for everyone. So as we were looking at changes happening and things coming to the future, we decided that it would be a nice time for the two of us to sort of talk about some emerging trends in how we look at our residents and how we evaluate them. And this will be, looking a little bit at what do we do here? What's going on behind the curtains in medical education? And also looking forward to a national level, what's coming down the pipeline for all of us, and what changes should we expect moving forward. So the CME color for this morning is going to be white. And we have a lot of content here, so hopefully we can keep everybody interested and engaged to sort of understand what's coming down the pipe here. So to start off things, we're going to begin with Dr. Scannell, and we'll introduce my co-presenter, Brian.
Thanks, Dr. Pat. So we, as Josh said, we have a lot of content to kind of get through today. So we will try to get through things sort of as quick as we can, but also leave some time for some discussion. So we're going to go through kind of the current state of resident evaluation here at CMC, and that's going to be the bulk of what I'm going to discuss this morning. Dr. Patt is going to talk about some of the future state of resident evaluation. He was very involved with a number of pilot programs that have been ongoing over the last number of years with resident evaluation. And then we'll talk a little bit about the future here and what all that will mean. So when we talk about professionalism and clinical development, what is our vision? Our vision from a medical education perspective is really to take our residents from this early PGY 1 year, from this beginner stage through the competency proficiency to that expert level when they reach early clinical practice. But bottom line, the big questions are what do they as residents really need to accomplish to get there? And from our perspective, from the academic team, how do we really know when they've done that? And so that's where evaluations and assessment tools really come into play. From my perspective as a program director, there are a number of things that I have to do at the end of graduation for our residents. One of which is for me to certify their ABOS application. So I have to state that the residents have met 51 months of graduate medical education, that they have met content accreditation achievement in order to apply for the American Board of Orthopedic Surgery. In addition to that, I have to do a summative evaluation to essentially say that our chief residents, as they graduate, are able to practice orthopedic surgery independently. So this is a big weight on the program director's shoulders. And certainly there are a number of things that help me as a program director and help our program to certify residents. So from a resident perspective, what we'll go through today is a little bit of how do residents get there. And then also from our perspective is how do we know from a competency standpoint when residents have reached that point. The two areas that I'm going to spend some time talking about this morning are feedback and evaluation. Feedback has definitely been a hot topic for us here at our own program, as well as on a national level through GME. Evaluation tools have continued to progress, and there's no doubt, and you'll hear from Dr. Patt later, they will also continue to progress in the future. I think as we talk about feedback and evaluation, oftentimes the lines between the two can be a little bit blurry in GME. Both are very much instrumental for learning and overall development of a resident. And there is clear data to show that those who receive feedback and respond positively to feedback will have improved performance, judgment, and learning in the graduate medical education arena. So when talking about feedback and evaluation, I think there's some important differences. Feedback is very informative. It provides information with a goal for improvement for the resident and is meant to be more non-judgmental. Evaluation is more summative. And it's really truly a process of ascribing a value to whatever is being assessed. So measuring it and trying to make that measurement as objective as possible. And ultimately to ensure standards are met for whatever the goal is from an evaluation standpoint. When Dr. Patt and I were kind of talking about things and putting together this talk this morning, From our perspective, feedback is really that personal and career development. It's what we are trying to give from an informational standpoint in order to help our residents continue to improve, to get them to where we believe they need to be when they graduate. And then evaluation is really the competency piece. And we'll talk through that a little bit more this morning. So feedback is clearly one of the most effective tools from an educational standpoint to help our residents learn and improve. I participated in the Stanford Clinical Teaching Program, which is overall a very good program in a number of different areas. But one of the things that we talked about was 5 features of good quality feedback. And I just wanted to review those today. The first of which is timeliness. So immediate feedback is clearly better than delayed feedback. Specificity of that feedback and really truly avoiding generalities as you're giving feedback. I think for me as a program director, what doesn't help me to be able to give feedback to residents is just, oh, that resident's doing great. We really need more specifics on what they're doing and where they can improve. Having a good balance of reinforcing as well as corrective feedback. So both that positive and negative balance is really important. If one is too much, certainly that can undermine some of the effectiveness. And then allowing time for learners or our residents to react and reflect, and then allow them to respond. And then finally, development of an action plan. And this is really where that improvement process for residents and reaching that competence and hopefully expert level by the time that they graduate really truly occurs. We know that residents want feedback. We did a survey here years ago, and it is very clear that residents want it more frequent, more timely, and want more explicit evaluation, or excuse me, more explicit feedback. Faculty certainly give feedback, but there have been some national studies that have shown that many residents feel like that's not enough. So I wanted to, just from a transparency standpoint, because we don't talk about these things all the time, we do 2 semi-annual faculty lectures every year. And so this year, during our faculty development lecture, one of the topics was feedback. And so I think it's important for our residents to hear this, that, you know, our faculty are getting some education on feedback and other areas throughout the year. And this is certainly an ongoing process. Feedback is not easy. It takes practice to receive feedback. It takes practice to give feedback. We talked briefly about different delivery methods, including more of an ask, tell, and ask. So allowing the learner or the resident to be much more active in that process of receiving feedback. The setting of that feedback, as we discussed in the faculty meeting, is so important. Immediate feedback and evaluation can occur in the clinic setting. It can occur in the OR setting, and that post-operative debrief, not just with the OR team, but also the resident, can be really key, I feel, for improving surgical skills and improving resident overall from a competency standpoint in the operating room. Mid-rotation and end of rotations are incredibly important and more important for the attendings working directly with those residents to give that mid and end of rotation feedback. So I do think that this is a two-way street. You know, it is, we're all in some very busy practices. And so I think it's just as important for our residents to reach out and to get in touch with the faculty in order to do these midterm and end of rotation feedback sessions. From an evaluation standpoint, clearly we have to, as a program, have feedback in order to give good feedback to our residents. And so a lot of that occurs in the form of evaluation tools. And so I'm going to spend a little bit of time on that and also discuss what is actually required of us as a program and discuss some of the specifics that we do based on these requirements. There's 3 main areas in the core program requirements for ACGME: formative and summative evaluation, as well as specific requirements that a program director must appoint what is called the CCC, or the Clinical Competency Committee. So we'll start first with some of the formative evaluation. So the core requirements are that the faculty must give feedback in a timely manner and evaluation in a timely manner following rotations. It must be centered around objective measurements of the 6 core competencies. And then finally, a semi-annual review of evaluation has to occur within each program. So when you look at what we have done over the years, MedHub has really been this long-standing formative evaluation tool that we have used here at Atrium. These are monthly evaluations, as many of you know. Not everybody has their microphone on, so I can't hear the moans and groans. But I think over time, probably the overall context of how probably faculty and residents feel in regards to MedHub evaluations has not always been positive. It does cover our 6 core competencies, so it allows us to meet those requirements from our common program requirements through ACGME. But there are many limitations to this. It has to be manually sent to faculty, so we have to know what faculty residents are working with. The summary evaluation is not always helpful. And oftentimes there are much more positive comments only in the comments section and not necessarily areas for improvement. As a program director, the piece that I probably worry about the most, and I pulled the data of where we stand currently with our overall compliance, we have over 100 evals of residents that are currently incomplete from 28 faculty. Now, some of these fall through the cracks, and the majority of people, there's just 1 or 2, and potentially some of these are very much duplicate that they're sitting in the MedHub space. But the compliance piece is probably the most important piece of making sure that we are completing these evaluations so that I can give proper feedback at those mid and end of year evaluation sessions. We've added a number of other formative evaluation tools over the course of the last few years. One is the night float evaluation tool. This is completed through REDCap. We are able to pull weekly aggregate reports. We really started this initially as I noticed that we were not really seeing feedback during the month that our residents were doing night float. And for those that don't know, during the course of a PGY 2 and 3 year, our residents are doing anywhere from about 2 to 2.5 months of night float. And so it's not an insubstantial amount of time that we need to make sure that we are truly giving residents the feedback and evaluation during those months as well. I'd like to thank Joe Hsu and Larry Kempton, as they have really taken on the bulk of this evaluation tool, both from completing them as well as providing residents feedback with a goal of doing this both mid and end of that night float rotation. We are also working on developing anchor points for residents as well as our evaluators. Another tool that we have developed over the course of this year is our intern evaluation tool. I noticed that as going through a lot of our reviews, we truly had a paucity of feedback for our interns. So we felt that those that probably work with the residents or the interns the most were our chief residents during their trauma months. So our interns have approximately 3 months on orthopedic trauma service where they're working very directly with one of the chief residents. We've incorporated a number of the core competencies into this as well, so that we can evaluate and kind of meet the needs of true competency based on what ACGME is recommending. And then finally, Grand Rounds evaluation tool. This was implemented at the beginning of this academic year, and this is done through REDCap as well, with some key elements that we have tried to give some feedback directly to residents. With their organization of their talk, their content, delivery of that content, and then signs that maybe residents have incorporated or maybe haven't incorporated previous feedback that has been given. That's really been taken on the evaluation tool by our academic leadership team. And what I would encourage faculty to do is that if there are comments during or after Grand Rounds, please reach out to me because I can incorporate a lot of that into this evaluation tool. Finally, from a formative standpoint, there are semi-annual reviews that we do. So twice a year, we sit down with our residents. This occurs at the end of the year and at mid-year. Myself as a program director, I meet at the end of the year with all of the rising PGY 4s and 5s and our exiting 5s. Dr. Kempton, one of our current APDs, meets with our rising 2s and 3s. And then at the mid-year, I sit down with all of the PGY 2s through 5s, and Dr. Kempton meets with all of our interns. There's a lot of information that's reviewed prior to these meetings. I go through comments from the CCC meeting, as well as the ACGME milestones, which I'll talk about shortly, review MedHub evaluations, go through OITE scores when appropriate, discuss and look at their CVs in regards to research, quality projects, peer evaluations, which we do once a year, reviewing their overall operative experience, making sure that we're meeting case minimums, which is rarely an issue for us at our program. And then discussion of any action plans. If we had put a plan in place 6 months prior, I want to make sure that we're following up on that plan and discussing that with our residents. So we're going to move on to the summative evaluation. And there are really two key areas here that the ACGME requires. And one is that we incorporate specialty specific milestones as one of the evaluation tools. And then finally, a summative evaluation has to be completed by me as the program director upon completion of the program. So ACGME milestones were developed a number of years ago and have certainly evolved over the years, but it's really truly meant as a framework of assessment for the development of the resident, with three main key areas of medical knowledge, patient care, and professionalism. Patient care also would include surgical skills. We in orthopedics have, I believe it's 41 different milestones. So there are a significant number of milestones for our subspecialty compared to other subspecialties. When evaluating the milestones, residents are essentially assigned a score of 1 to 5 based on what you see here. So it really looks at overall level of competency and where they stand in regards to overall competency in residency. So when you look at the milestones over the course of the years, we've developed and put our milestones into more of a heat map that we can show our residents and share with our residents semi-annually. For me as a program director, this is visually very easy for me to kind of look at. What it helps me with is to kind of see if there's certain areas where a resident may be behind in their medical knowledge, in their patient care, or any of the other areas of the core competencies from the ACGME standpoint, like professionalism or communication. Again, we present this semi-annually. I'll put one other comment in is that Susan Colstam has been absolutely amazing in helping me to put these together over the course of this last year. I think this is a really important thing for our program to have. We modeled this after University of Chicago, who was doing something very similar. I want to spend a few minutes too on the clinical competency committees. So this is a core requirement of the ACGME. When asking residents probably 6 months ago about what they wanted to hear about from an educational standpoint, I think there was at the time, and maybe there still is, a little bit of what happens at the CCC. I think there are certainly some that are a little bit anxious about what happens. And so this is intended to be a little bit transparent in what goes on and what's the process that we use here. We certainly take the guidelines from this guidebook, but a lot of what we've adapted over the years has been for us as a program to figure out how best to improve our residents overall from a competency standpoint as they progress. So what is actually required? Well, me as a program director, I have to appoint CCC members. We have to have at least 3 members on the committee. We have to have a written description of our overall responsibilities. We must review all resident evaluations semi-annually, determine residents' progress in certain specific milestones, specifically the ACGME milestones. So all 41 must be reviewed. And then we have to, again, meet semi-annually, and the committee helps to advise me regarding each resident's progress. And ultimately, from the standpoint of ACGME, this comes down to accountability, so that we as medical educators can help to kind of certify or be accountable for high quality, safe care graduates who meet standards of care within our local area. The purpose of the CCC, I'm going to kind of go through it from a program standpoint, PD standpoint, faculty, residents, and then ACGME. From a program standpoint, it's really to develop a shared mental model of how performance should be measured. There's definitely going to be differences from program to program. Expectations are going to be a little bit different from program to program as well. It allows us to increase our quality and reduce the variability of performance assessment. And I think this is probably one of the more important things that we have done over the years, is that as we sit down and actually discuss our residents, we're really decreasing that variability in how we evaluate residents, which is so important. It decreases potential biases. It helps us to identify weaknesses in our program. It also allows the system to identify early on residents that may be struggling, and for us to potentially put in an action plan to help them so that that doesn't continue to be an issue for them. From a program director standpoint, it allows me to fulfill that public accountability to help make sure that I can certify a resident is ready to practice independently. Getting together this group of faculty allows me to create buy-in from our faculty in assessing overall resident performance. As a PD, I'm able to advocate for residents, and I truly believe that it allows me to give better feedback to our residents, not just because I'm able to get more feedback from our residents, but the feedback that I'm giving to our residents at our semi-annual review is coming from our group of faculty, our core faculty as our subdivision chiefs. I do think that it adds to a little bit of the credibility of that feedback. From a faculty standpoint, this allows us to fulfill the professionalism inherent to the faculty role in teaching and assessing our residents, to unify what a resident should look like from a performance standpoint, and to improve documentation. So residents, what do you get out of it? Well, I think it improves the quality and honestly the amount of feedback that you get and you receive. It does allow for earlier identification if performance is not where we feel as a committee that it needs to be, and helps us to avoid things like remediation, probation, etc. It improves overall goals that I can give you and work with you to give. And it allows us to develop action plans for the future. ACGME, and we kind of talked about this initially, but the ACGME, it's really about that public accountability. And allows us to evaluate overall competency, and will allow us to establish more national benchmarks for the trajectory of a resident skill, and the documentation that is needed from a GME perspective. So here at CMC, this is our CCC committee. It is made up of myself, who chairs the committee, our two program directors, Dr. Hammond and Kempton, each of our division chiefs, and then one at-large position. So we have over 10 faculty that are involved. We actually just had our CCC meeting Tuesday night. I think as Josh and I were putting things together, we didn't realize how much we had going on when we elected to do this talk at this time, but it certainly helped me to kind of frame the CCC meeting on Tuesday again and get everything straight. The prep before the meeting is probably the most important thing. So each of our subspecialty chiefs evaluate the milestone scores. My ask is that they send those scores in prior to the meeting. It allows me to review things, which is part of our role, or my role. Subspecialty chiefs talk to the subspecialty faculty that have worked directly with those residents in order to develop those milestone scores and to get further feedback for the CCC meeting. It's my role to kind of synthesize and look at all of the milestones, which I review prior to the meeting. So I'm reviewing 41 milestones for 26 different residents. So our faculty did a great job this year of getting everything into me in a timely manner. Our associate program directors helped me with the minutes and getting any updates on action plans if there were any, and also review the academic update forms that we request that the residents send in to us semi-annually. That preparation before the meeting is so important. It allows us more time for discussion rather than just reviewing the scores of the milestones. I review all that prior to, so certainly if there are any issues or discrepancies, we can review that and discuss it. But it allows us to have a much broader and I think more rich discussion of our residents in order for me to be able to give better feedback to our residents. The design of the meeting has really helped us to identify overall competency. And I would say as you look at the meeting discussion, I'd say the majority of our residents we feel are very appropriate for level. There are certainly residents that we feel like are above level. But what I think the committee has really helped us with over the years is identifying if we feel that someone is at that suboptimal performance, it has helped us to identify that much early on in training in order to help improve so that we do not have issues like remediation or probation. If someone's exceeding standards, we definitely, and this is conversation that we had on Tuesday night, of how can we help our residents further, whether it be from a research perspective, leadership perspective, or other ways through career development. And if the data discussion raises other concerns and specific areas of concerns, we can put into place an action plan to help avoid any further issues. And the way that I've really looked at this is breaking things down from the domains that we really see most often, including cognitive, professional, communication, and clinical competency, as well as surgical skills. So residency has certainly changed. Our overall means of assessment has absolutely changed as well. And so I'm going to turn things over to Dr. Patt, who is going to talk a little bit about what the future will hold for us and what's coming down the pipeline for us. Josh, you need me to pull it up?
Nope, I couldn't unmute myself. I got this. The talk wasn't the issue. It was unmuting myself.
Okay.
All right. Does that look good? You see it, Brian?
Yep, we're good.
All right. Well, thanks. That was a fantastic job from Brian, and sort of reviewing what's happening now, kind of a look behind the curtain at what the Wizard's doing. What I want to sort of evolve to here over the next half of this talk is to look at what's coming. So I think that we have really evolved how we do things and really done a nice job, especially in the last year, of really focusing on our learners and how we review them. But what I've been working a lot on in the background through mostly my role in CORD and working with the ABOS is sort of, what does the future of resident assessment look like? And we've talked a little bit about this, and I've participated in a few studies that I've forced all of you to be part of. But I think that what's coming is now more formulated. I think that there's a clearer vision from the ABOS. And then the ABOS, for anyone on the call who doesn't know, that's the American Board of Orthopedic Surgery, is really driving this change in the assessment of orthopedic residency trainees. So there's been a global look at trying to evaluate residents on a competency level. This is termed competency-based medical education. And this is certainly a goal of the ABOS to sort of focus on the CBME model. And this approach really works to try and ensure that graduates develop the competencies needed, sort of that public accountability, to get our residents and future caretakers to fulfill the patient's and society's needs. What it does do in this competency-based model is de-emphasizes the time-based training element and promises greater accountability, flexibility, and learner-centeredness. So how has the ABOS framed this? Well, they really went back to the drawing board and looked at what are the key elements of being a resident, of being a surgeon, and how do we best accomplish this? So it was broken down into a triumvirate of knowledge, skills, and behaviors. So we're going to look at how the ABOS has sort of focused these three elements and how we're going to do a better job of evaluating residents in the context of this model. So starting out with knowledge. So I think knowledge is probably the one element that has been most consistent for the last 20, 30 plus years in orthopedic education. The American Board of Orthopedic Surgery has an established endpoint. At the end of your residency, you take the ABOS Step 1 examination. So that exam is carefully designed, vetted by the National Board of Medical Examiners. They have these psychometricians who look through every single test. 10 to 20% of the questions you get on the ABOS annually are actually not even scored questions. They're actually test questions. They're testing the questions to see if they have a reasonable amount of discriminatory capability. So what we have during residency, so that's what Dr. Scannell and I want to know is, how is a resident doing while they are in residency? And what we've used for years, again, is the OITE exam, the Orthopedic In-Service Training Exam. Almost every subspecialty has their own version of an in-service exam. And what we all know, and everyone in this call who has taken the OITE knows how frustrating the OITE can be. It's a very inconsistent model. And in comparison to the step one examination, which is carefully designed, each question is designed and thoughtfully and analyzed to make sure that it addresses certain elements of training. The OITE is a little bit more haphazard and honestly a fairly unreliable test. So if anybody ever looked at the disclaimer on the bottom of the OITE, it actually says this test not to be used for advancement of orthopedic residents. So if you're getting ready for the test, you'd think, well, of course, I'm taking a test to see what I know, to see if I'm ready to move on, to see if my quality meets the expected quality. Well, because of the design of the test, it's actually not even capable of doing that. So the ABOS's goal was to improve the quality of knowledge assessment throughout training, from internship year to 5th year. So we don't just have this one make or break test that everybody has to take at the end of their residency. So in order to do this, they actually introduced some ideas that were a little bit controversial. They initially introduced, I think 2 years ago, an idea, hey, we are going to move the board exam, move step one into the residency space. We're going to offer that examination to people who think they're ready to take the test in year 4 of residency. So there was some good debate back and forth from the learner's perspective, from the program director's perspective, and there's some challenges to making that big transition, but it's not unprecedented. This is actually a technique that is done in several specialties. I don't know if any of our neurosurgery colleagues are online, but they actually take their written boards starting in the 4th year of their residency. They can opt to take that exam. So again, it has been done. Looking at the logistics for us, there were some concerns about how that would roll out. So the ABOS was very open and said, okay, if this is not going to be the best option for program directors, not going to be the best option for the AOS, who services the OITE currently, what could we do differently? Hey, let's all get together. And if we really want to evaluate medical knowledge, let's change the test. So what we did was a group of us got together in Philadelphia just before the pandemic, and it was my last time on an airplane before COVID set in. And we met in Philadelphia, actually at the offices of the MBME. And the first meeting was really set to focus on the blueprint. So the ABOS has a blueprint. This blueprint is actually publicly available. If you go on the ABOS website, you can actually search blueprint, and it'll tell you, hey, this is what's on the test. So using my tumor bias, I decided this one would fit on one slide so I could show it to you. But this is what the blueprint looks like. So they have big categories such as neoplasm. So neoplasm on the average step one test is going to occupy anywhere from 3.5 to 10.5% of the exam. Then you can see they've tried to prioritize what are the important things that people need to know. It's very thoughtfully done, and they have subject matter experts in the room looking at these various domains. But what is a practicing orthopedic surgeon going to see? They're going to see benign bone disease, and they're going to see metastatic disease. So you can see here, those are clearly represented in the highest percentages. So as follow-up to that initial call where we worked on the blueprint, we had a collaborative virtual discussion in April where we really coned in on the OITE and said, all right, how can we make the OITE better? Obviously a short timeline since that test was coming up in November, but we used the step one blueprint from the ABOS, tried to frame those questions better around what really needs to be on there content-wise. And there was also an agreement that we were going to actually try and validate some of these questions. So you can't validate 350 questions or 340 questions in 1 year. So it's going to be a stepwise pattern. So the goal for this year is going to be that they actually had some questions on there, about 20% of them, that are not going to be released. And we're actually going to try and validate those questions. And some of those questions are actually going to appear on the Step 1 exam this year. So by using validated questions, it's going to make the OITE a more standardized test, and it's going to allow us to use it as a formal measure of that knowledge domain. So the next portion of this grouping of concepts is skills. So all of you who have been here on faculty for a few years and some of the senior residents know this very well. So the ABOS and CORD participated or created a study where we actually looked at how do we evaluate surgical skills. And this is a study that was published in JBJS, and we were one of the participating centers, where we compared two different scoring systems, an O score and a P score. The O score is a validated system from Ottawa that looks at how do we assess surgical skills. And the P score or P tool was really more of a summative evaluation of someone. So in looking at all this, we looked at the resident satisfaction, the number of submissions, and faculty perceptions of this, and realized that there's actually some really nice elements of both tools. So we sort of trimmed it down and made a combined tool to use for skill assessment. And the nice thing is, through the ABOS website, the program director can actually print out these skill assessments and feed them directly into some of the ACGME milestones. As you can see on the right here, a couple of graphs from the study itself, it does a pretty nice job of evaluating competency in surgical skills. As you can see, the white bar representing independence in practice, and we go from PGY 1s where there was 0 independence, although there was only one submission. So let's ignore that one. We'll call it a PGY 2. And then PGY 5 year, where greater than 95% of the submitted assessments showed competence. So this provided us a nice tool to focus on that skill element. So as part of this, we actually got a lot of data, as you might imagine, from 16 centers collecting all of this. And what we were also able to do is look at what cases are residents doing. You know, the ABOS publishes this every year based on the Step 1 examination, or excuse me, Step 2 examination, the practice-based portion of the certification exam, and looks at what are the most common orthopedic procedures. Well, this gave us some insight into saying, hey, what are residents doing? And I know that this is too small for most people to read here, but you know, up at the top there are femur, knee, repair, revision, reconstruction, pelvis, hip, repair, revision, reconstruction, hip fractures, knee fractures, total knee, total hip, knee arthroscopy, ankle fractures. So they are the things that we all think of that a competent orthopedic surgeon should do. So that's that high frequency group. The medium frequency group was things that were, you know, also important, but not quite the same volume. Low frequency, nobody would argue that there aren't important cases in this low frequency group. But when looking at this entire cohort and seeing only about less than 10 cases of people doing these things, we realized we can't really expect true competency. We can't even set a bar of what competency is with such low frequency. So we decided to shift the lens to the left here. And in our most recent group meeting with the skills team, what we did is we broke the initial skills down into 35 we could determined are core required, and then 53 essential exposures. So the 35 are really going to be the ones that we want to see defined levels of competency for all of our graduates. 53 are the ones that, yeah, you really shouldn't leave residency without having seen this, without having some exposure to it. And it helps give guidelines for program directors to make sure that they are providing the correct depth and breadth of education. So for an example, I pulled up the pediatric skills here, and the core required, again, irrigation and debridement, ORIF, then essential exposures, supracondylar humerus. So if you look at the data from most residents, the average is 4 to 5 supracondylar humerus fractures in a residency program. And while that's good, is that good enough for competency? Probably not. So I think that's why that type of procedure ends up in the essential exposures group. So in addition to the surgical skills portion of this, the ABOS, along with CORD, is actually working on a non-surgical tool as well. This is going to focus on how good are we at closed reductions? How good are we at physical exam? How good are we at history taking? And these will be some other elements that we include moving forward. So now let's move to the last piece of the ABOS knowledge, skills, and behavior model and talk about behaviors. So again, something all of you are probably familiar with. Last year, we participated in the behavioral assessment pilot tool. And at the beginning of that tool in the background, which all of you didn't know, is that each program director looked at every single resident and went through and did a baseline assessment looking at their behaviors in all of these domains. And interestingly, once all of the data came back, there was only 32 residents, which accounts for less than 2 per program, which is nice to see, who program directors were concerned that they would be suboptimal in terms of their behaviors. But 26 of those 32 were identified with the assessment tool moving forward, which means that program director baseline had about an 81% sensitivity in concordance. Importantly, it also identified about 176 residents with at least one low scoring domain. So this is so important for program directors. This is what we want to know. We want to know, what is it that we need to focus on? You just say teach professionalism. That's a pretty broad concept. But if you say, hey, this person is not good at talking to office staff, well, that gives us a more discrete element, a more discrete focus that we can try and hammer down and drill down in our learners. So again, while this didn't identify a huge number, this group of outliers may be the most important for us to identify. So what does the behavioral tool really look at? So there's a couple of measures. And while I'm reading through these, you can look to the right, the far right column there. That's the percentage of all of these that had more than 2 low scores within the same domain. So again, not a huge number, but if we're looking at trying to figure out who could not be an excellent doctor, who is not going to be that person who is a benefit to their community. If we think about malpractice suits, why do malpractice suits happen? Occasionally they happen because of bad technique, but the most frequent causes for medical malpractice is patient dissatisfaction, communication issues, and even ethical behaviors. So those are the things that we want to identify. It is rarely pure skills or knowledge that account for a medical malpractice suit. So these behavioral tools allow us to look at how our learners adhere to ethical principles, how they effectively interact with patients and with the people who are important to these patients, i.e. family members. How effective are their interactions with other people working within the health system, looking at reliability, teamwork, commitment to autonomous maintenance and continuous improvement of competence in self, others, and system. This feeds directly into the concepts of burnout and moving forward with a happy life and a balanced life. So this ABOS framework provides us with a longitudinal assessment of resident knowledge, skills, and behaviors that are really going to be the key components of our evolution to this competency-based medical education model. Successful documentation of these domains will be the requisite for board certification process in the future. The American Board of Orthopedic Surgery has stated that very clearly. So we need to be a part of that. We need to learn how to evaluate it from our teacher standpoint, from our learner standpoint. We need to document it. More importantly, Dr. Scannell pointed out the number of missing documents just from MedHub. So we can't do that. We will be hurting our residents if we don't, maintain our participation in this. And I'm going to show you in a minute what the resident dashboard is going to look like, which is going to end up being a part of the resident's educational portfolio. So Dr. Scannell spent a bunch of time on the ACGME, and I don't want to spend too much time going over this, but I think it is good, as we just spent so much time looking at the ABOS, to really understand how does the ACGME fit in? Are they complementary? Are they something different? Well, they really are different. So we talked a little bit about the milestones, and we talked about the number of milestones. We have 41 milestones. Just in case anyone is wondering, that is 1,066 data points that we need to submit to the ACGME twice a year as determined at the CCC. So quite a bit of work that goes into doing that. Nobody in ortho is happy with that. We have the most milestones of any subspecialty, not something we want to be proud of. I like to blame Dr. Frick for that, since he was on the original milestones committee. So why not blame him? So Milestones 2.0 is in progress. We have a group including 5 representatives from CORD who are working hard to sort of redo the milestones and make them more user-friendly and feed closer into what we're trying to do with the ABOS. So what the ACGME does, as Brian clearly stated, is they are about programs. Even though we give them resident level data, so obviously the milestones are resident level data, they are not making an assessment of the competency of our residents. What they are doing is they are looking at the milestones data and deciding, are you a competent program? Does your program provide the exposures, the education that your residents need to be successful? So it is really focused on the program itself and not the residents. Certainly we use that resident-based data to help us teach and help us give feedback to our residents. But really that's what their focus is. So the ACGME creates many guidelines for programs, but really they aren't specific to resident evaluation other than saying you have to do it. So what are the other important pieces of data that they get? These are important for all of you to know. So in the late winter, early spring, everyone gets, or not everyone, most or every resident and some faculty get the ACGME survey. These are critically important. If we do not have participation in this, we do not answer all these questions, it is a clear negative about our program and can show up in our program review. We also annually fill out the accreditation data system, ADS. This includes program data, surgical case data, faculty scholarly activity, resident scholarly activity. So all of these things that we are constantly demanding of you, these are critically important to the accreditation of our program. And really that's one of the goals of today's talk, is to let all of you know, why is the things that we ask for important? So moving on from the ACGME, I just wanted to have a little interlude on that. Let's talk about the future state. So we talked for the first half of this talk about what we do now. What are we going to change moving forward? Well, what we're changing is that we are going to be clearly integrated in the strategic rollout of the knowledge, skills, and behavior work from the ABOS. This is going to be required, so why not lead from the front? So this is the resident dashboard. This is a mock-up of it, so it's not ready yet, but this is eventually what each resident is going to be able to do. And the program director, they're going to be able to log into the ABOS website and look at this dashboard, and you're going to know how I'm doing. I mean, that is the most common question our residents ask us, and they ask themselves throughout the 5 years of residency, how am I doing? They have no idea. So that's our goal, is to provide them with the data that really says, hey, here is how you're doing. You want to know how your knowledge is? Here's your knowledge. Here's your OITE score, and here's the ABOS standard. Here are your skills competency. Here's the standard. Here's where you are. Here is your exposures. This is what the requirement is. So I think one of the key elements here you can see is that for the core procedures, they're defining competency as level 4 or level 5 efficacy. Whereas for our required exposures, meaning the things that are in less high volume, you don't necessarily have to be independent in it, but you have to be exposed to it. Next is the behaviors. You'll see where you are in the behaviors standpoint, where you were at various points in your career. Looking at skills non-operative. Again, this is closed reductions. This is physical exam, history taking. And then finally, documentation of what rotations you did. Right now, this lives in a mysterious space, and we have to try and remember where the heck it was every year, as well as you. So this resident dashboard, again, is going to allow our residents to really track their own progress, and it's going to allow the program director and the program to understand how are these residents moving forward. And this is going to feed directly into this hybrid competency/time-based model. Additionally, this is what we want. If we're going to be requiring people to put in more data, if we're going to be requiring more paperwork, more graphs, more charts, more clicks, we want that to be useful to us. So they've designed it to be useful for us. So we are going to be able to take that dashboard and create a CCC report, which is going to have data for us on the level of competency achieved in every skill assessed, It is going to have the non-operative evaluation skills and level of competency. It is going to have our behavioral assessments. So what this really does is it provides a true comprehensive look at what our residents do. It is going to provide better feedback and more real-time feedback for our residents. It provides incredible granularity for our program director for the CCC. I mean, the amount of prep time that Dr. Scannell has to do is going to drop significantly when all of this data is printed out in a chart for him. It is going to dovetail better into the milestones. So I will tell you that CORD and ABOS are lobbying hard with the ACGME. About 3 weeks ago, I presented at the ACGME Congress to the policymakers at the ACGME on behalf of ARCOS, which is our Program Coordinators Association, the ABOS and CORD, and said, here's what we need. We buy into the changes you're making, but here's what we need. And these are all things that are going to help us. So one of the things we want to do is get rid of duplicative work on the part of our residents. So, you know, right now, the residents have to log in and do a surgery log for the ACGME. And then they have to do a surgical skills assessment. So what we're asking for is when they put in a case that logs into the ACGME for a case they've completed, that should automatically generate a surgical skills assessment form, and that gets pushed out to whoever they select as the faculty involved. So these things are automated, so they move forward quicker. It's actually going to give us better data. We're going to understand what our residents are doing. But if any of you have ever come to one of our annual or monthly resident conferences, you can hear Dr. Scannell go through the report of who is delinquent on their surgical case logs. This is going to require compliance. It's going to require compliance by the residents. It's going to require compliance and work by our faculty. But we hope, and that's why we wanted to really share all this with you, we hope that this is going to make for a better educational process. It's going to make us better learners, better teachers moving forward. So ultimately, using this dashboard and what we've designed, we want to try and define the educational standards for graduate medical education and orthopedic surgery. And this is our opportunity to, again, lead from the front and help provide real-time feedback in the training of competent orthopedic surgeons. So going back to one of Dr. Scannell's early slides, the ACGME has a core competency that you must evaluate each resident in these 6 core competencies. So how are we going to do that? We are going to do that within this knowledge, skills, and behavior framework. You can see here how all of these track, and again, how we also have them designed to feed directly into the new milestones update. So what are the changes coming? So changes are coming soon. So the timeliness of this meeting was for a couple reasons. One, we don't want to just tell you you have to do something. We want you to understand, why are we asking you to do it? Why is this important? Why are we changing? So we are changing. We are intentionally changing the way that we evaluate our residents. So the behavioral skills surveys, which all of you got for a 12-month period last year, they are going to start coming out again in January. At each rotation, you will be getting a behavioral skills survey, and these will come, and we need to have those filled out. We need better compliance, please. We do want you to be honest too. There is some ceiling effect on those, but I want you to really think about things. The residents are going to get feedback on their behavioral assessments at the end of the year. So that provides a little bit of blinding to the data and gives them a bit of a more average over the 12-month period. But we want to be honest with the residents and really give them a good understanding of how they are in that behavioral domain. We are also in January going to start pushing again to complete the surgical skills assessment. So again, these will be done through that ABOS platform. And our expectation is that we will find 1 to 2 cases per week that each resident can be evaluated on. These are going to be collected and into this dashboard for the ABOS. So there is no better way for us to prepare you for when this is going to be mandatory, which is not far off. Based on my predictions and discussions with the ABOS, people who are interns now will likely start being involved in when they come to apply for their ABOS board certification. This is going to be reviewed. So the integrity of the data, the quality of the data is going to be really important moving forward. In the knowledge domain, so the OITE this year was already different. It was already changed in terms of test design. Again, about 20% of those questions are going to be held back so they can retest them on the step 1 test. This will change how residents prepare a bit. You know, many of you, especially from my generation and before, remember getting the old paper version of your OITE back, and we would all go through and answer questions and share them with everybody. Well, that's not going to be the easy way to study anymore. So we're having to use new knowledge sources. And we are working together again. So the AAOS has developed a new curriculum. Their curriculum is focused and based on the ABOS blueprint. We have program directors and CORD involved. We have the ABOS involved, trying to design a curriculum that is going to be the best interface for residents, and is going to be most true to what is needed. So yes, this will be, this will be competition for some of the other existing things like OrthoBullets, Res Study, and JBJS clinical classrooms. But its focus is really trying to be resident centric and focus on the essential knowledge that they need. So we're asking a lot. Dr. Scannell and I understand that each survey you get, each text you get to fill something out is more work. Our goal is to begin phasing out some of our historical evaluation systems. We would like to completely get rid of MedHub, to be frank, but we have to still meet those ACGME requirements. So if we are not doing all of these elements, if we are not assessing knowledge, skills, and behavior for each resident on a monthly and rotation basis, we will not be meeting the ACGME standard. So we have to be able to document that. So we really need to have buy-in from our residents and from our faculty in order to be able to do this. Remember, as part of this discussion, the ACGME is parallel to this. It's not the same, but you will still be getting the ACGME surveys, the faculty and resident surveys, and we'll still be filling out our ADS, but reporting upon the new systems that we use. And we are actively working, like I described, with the resident surgical log to try and integrate many of these systems as best we can and get coordination between all of our partners here. So in conclusion, this is really, again, this is a repeat, but this is our opportunity. We can really set and define the educational standards for graduate medical education in orthopedics. We are ahead of many, if not almost all other subspecialties in our laser focus from our board on trying to make this a meaningful evaluation. And the best byproduct of this is all of it is going to only lead to improved feedback and better evaluation of our residents. And we know from lots of studies, including ones that we've done here and ones we participated in, that is important for resident satisfaction and development. And we do remain focused on streamlining all of this because we know that there will be extra work involved, but ultimately our goal is to, by coordinating all of these data elements, really allow us to streamline this process for all of you. So thank you all for listening to Dr. Scannell and I. And now if everybody could turn their cameras on, we have about 10 minutes, maybe not 10 minutes, maybe 1 minute, but we'll call it 10. We're open to any questions, both Dr. Scannell and I, from anyone.
Josh, just a comment, just greatly appreciative of the work that you and Brian have put into this. And it's fabulous having you in your position with CORD to bring this back to us and keep us on that forefront. I think that's what will really put us in a great position for generations of residents to come. So, and also appreciate the explanation, because sometimes when you get these pings for these surveys or whatever, it can be a little annoying. And I think it's very helpful to know what this is really going towards. And I know everybody will be a lot happier to participate knowing these facts.
That was certainly one of our goals today, was to try and make it less mysterious what's going on behind the curtain.
Any resident comments?
Dr. Patt and Dr. Scannell, this is Kelsey. I was just wondering, you mentioned the next round of the behavioral assessments is coming out soon. Will the residents have access to the feedback from the last round of that in this upcoming CCC cycle, or when should we expect to hear about that?
Yes, that was actually one of the program director's complaints to the ABOS, who sort of led the study, was that we didn't get that feedback back, and we said we really need that moving forward. So we have requested it, and I think that we should be able to get the information from the previous iteration, but certainly we will have it moving forward. As I mentioned, the plan is to try and give that to probably annually, but it'd be nice to give it a little bit more frequently. But I think that there was some concern, just about the, people are afraid to give feedback, frankly. People are afraid to give negative feedback even more than just giving feedback. So, there wanted to be some grouping or clumping of it. Because also for the residents, I mean, if you have one person who, evaluates you and it wasn't a good month, we don't want it to look like, oh, you're terrible. We want to give you a little bit of an average, a little bit of a broader look at that. But also take that as a reminder, Kelsey. Thank you. All right. Well, I will.
Hey, Josh.
Yep.
Hey, it's Kevin. I just wanted to see if you guys, for your 4s and 5, like if you get up to the upper levels for whenever you're looking at those milestones, if you, or hopefully maybe you guys are better than what ours are. Have you found that a lot of those are very unrealistic for residents to achieve during the course of their training period? Some of them go, for us, it's even like, be thought leaders and scholar.
Yeah, I think, Kevin, I think that it was a great
dissemination and everything else that are far and beyond what usually.
Yeah, I think that was
not for our residents, Kevin.
Yeah, we have no problems achieving that, Kevin. We're all thought leaders. No, so I would actually say that was an initial complaint when people first got the milestones, because they figured that that it meant by the end of, and it was probably even more difficult in orthopedics because we happen to have a 5-year residency. So people thought that the 5 levels of competency equated to what year in training you were. So it took some education of our faculty to sort of let people understand this is not supposed to be your, level 2 when you're a 2, a 3 when you're a 3, because we don't actually require people to get to 5. It is not the ACGME's expectation that people are going to be level 5 for graduation. They actually hope for, their aspiration is that everybody's a 4 by graduation. So that effectively eliminates that thought leader portion. But we find it very helpful when we talk about our residents in the CCC, because that actually helps identify who are those potential leaders, who has actually done an independent prospective study on, total knee arthroplasty and been essential to the design of that study, who is going to move forward in that domain. And those are the people who hit that level 5. But it's really not necessary to hit a level 5. So I would agree that it's some of it, if you just look at it on the surface, sounds like it's unrealistic. But if you kind of get a better understanding and properly educate everybody, it's pretty reasonable.
So to T's point, have you applied those same milestones to the faculty members to see where they lie now?
Have not.
No, we haven't.
Or maybe just T. That's fine.
Perhaps the behavioral assessment would be a better one to start with.
Or the non-operative skills. Do we still remember how to reduce a fracture and interview a patient? All right. Well, thank you to Brian for helping put this together with me. And hopefully this was helpful to everybody to sort of understand what's happening and how we evaluate, and also a little preview of what's on the frontier. So It's not a mistaken text or assignment of a new survey for you when you start getting those in January. So please fill those out and help us get rid of some of the old stuff. Out with the old, in with the new. So thank you all, and everybody get to work.